Now I'm going to begin the examination. I'm going to begin the clinical examination of ear first. Before any examination, you have to introduce yourself and also inform the patient what you are going to do and take his consent. I will say that I am Dr.Shakil है, मैं आपको मुआयना करूँगा आपके काम पहले लाइट से दूर से देखूँगा फिर करीब से देखूँगा आपको कोई एतराज़ तो नहीं है इस तरह पेशेंट से आप consent लेंगे. Now when we examine the ear, we will start with the right ear. Okay. First of all, as any clinical examination, you do it with an inspection. So you switch on the light and you examine and inspect it. You can increase the diameter of your headlight because you want to see the whole area. What you want to do is examine not only the pinna, the periauricular region and the post-auricular region. You want to see any obvious deformity. Some patient may have got a congenital deformity. They may have an absent pinna or a small pinna, or which we call it microtia or rudimentary pinna. Somebody may have got meatal stenosis. They may have got any scar, which is more common if they have any previous surgery. They may have any swelling. If there is an acute infection of the mastoid, there may be post-auricular swelling. There may be any birthmark or any pulsation. So you basically do the inspection and then you do the palpation if there is to see any tenderness. So when you are doing inspection, first do like this and then you push the pinna forward and you can examine the post-auricular area for any scar or any mass. So this is inspection. Once we have done the inspection, we will start do the palpation. So you very gently explain to the patient that I am going to touch the pinna. इसमें दर्द तो नहीं होता हाथ लगाने से? Sometimes because the reason I have asked this question in some patient who have got a boil in the ear canal or acute otitis externa, as soon as you touch the pinna, they will jump. So you need to know there is no acute inflammation or acute infection because we do not want to cause any discomfort to the patient. The essential of examination, you must do a clinical examination correctly, completely, without causing any discomfort or anxiety to the patient. Once we have done the inspection, so I'm going to palpate the periauricular region and post-auricular region in the mastoid area. And then I will tilt the pinna upward and posteriorly, like this. You can see a lot of things inside the ear canal. You can look in whether there is a wax in the ear canal or not, if there is any secretion, any mucus or pus, or any polyp, or any foreign body in children, and sometimes you can even see that eardrum. So when you are looking inside the ear canal, you have to look at the ear canal in first, the color of the skin, and see if there is any wax, any foreign body, any pus, any pollen. Then you pick up this oral speculum. Since we have done inspection, so you should know what size of this speculum we have to use. They come in various sizes. And it is better to use the largest speculum which can fit in the ear canal without causing any discomfort to the patient. So there are various sizes of ear Seagull speculum come. These ear speculum are called Seagull speculum. This is the small narrow one, this is the wide one. But this patient has got a very wide ear canal, so I am going to use the widest Seagull speculum which is available. Come close to the patient. If you are examining the right ear, we hold it in your right hand. If you are a right-handed person, okay. So I am a right-handed person. I will hold it between index finger and thumb like this, and ask the patient to lean his head against the headrest so that patient does not move. Because if they move and I am putting it there, they cause trauma or discomfort. In adults, you pull the pinna upward and posteriorly to straighten the ear canal. In children or infant, you just pull the pinna inferiorly. Now once you have done that, you very gently put the insert the Seagull speculum inside the ear canal. And you see again the structures which I have mentioned before, the ear canal itself, for any secretion, any pus, any polyp, or in children any foreign body, and then look at the eardrum, whether the eardrum is intact or if there is any perforation. If eardrum is intact, where is the handle of the malleus, cone of light? These are the normal structures which you see in the ear, in the trypanic membrane. So this is how you hold one with your index and middle finger and thumb, and you can examine like that without any discomfort. Once you have done that, if the ear is infected and you want to examine the other ear, you must change the ear speculum. Don't use the same speculum. Now once you have finished the inspection, palpation and examination of the ear with the seagull speculum, then you want to have a closer look. You switch off your headlight, you pick up the otoscope. It is best to hold the otoscope like a pen, like this. The reason we use this position because we can maneuver very easily the otoscope. If you hold like that, your grip is very tight and it is difficult to maneuver, and if you are looking inside, you may cause trauma to the ear canal. So with this you have got a firm but not very strong grip, a steady grip, and you can easily examine. Whenever you are examining, you must use this oral speculum, which you put it there and turn around, and then it fits into this notch there. I have noticed even during the annual examination, a lot of students are using without this. So you must use this. And then again, what we are going to look inside the ear, as we did with the seagull speculum, ear canal, any abnormality, any secretion, any pus, any polyp, and then the tympanic membrane, if it is intact, is it normal color, which is a grayish white. If it is normal color, if it is not normal color, if it is red, or which indicates an acute infection of the middle ear, which we call acute otitis media, or if it is retracted. If there is any perforation, then you must locate the perforation, whether it is anterior to the handle of the malleus, posterior to the handle of the malleus, whether it is in the pars tensor or in the pars flaccida, that is atically. So basically, I am going to focus on clinical examination. I am not going to discuss or explain any pathology in this video. So you switch on from here. There is a small button there, and then you look in on your palm, so that you want to ensure that the intensity of the light is good, your batteries are charged. Okay. And then again, as I said, right ear, right hand. You pull the pin up upward and forward, and then you look inside the ear canal, like that. Sometimes when the eardrum is retracted, you want to assess the mobility of the eardrum. So for that there are various ways. You can ask the patient to do a Valsalva. What is Valsalva? Ask the patient to pinch the nose and blow with their mouth closed like this. So if the eardrum is mobile, it will move. The registration tube is normal, that it may move. The second method of assessing the tympanic membrane mobility is to use the pneumatic bulb, which fits there. You put in the inside the ear and then check the mobility by pressing some air. Okay. So first of all, and then you look inside like that, and then you can look with the otoscope as well. Okay. And then with the pneumatic speculum, so you hold it like this, and you check the mobility. Okay. Just now, a few seconds ago, I had the otoscope like that, just to demonstrate that this is the wrong way to hold it. You must hold it like this, just to emphasize my point. Okay. So this is your inspection, palpation, and examination with seagull speculum and with the otoscope is finished. You repeat the same on the left side. And once you have done it, then we want to do a hearing assessment of the patient. So you take off your headlight, and what you do is obviously hearing assessment. You want to do an audiometry, but before audiometry, you can have some idea by doing various type of simple clinical tests to give you some idea about the threshold of the hearing, whether the patient has got a normal hearing or abnormal hearing, and if the patient has got a low threshold or deafness, whether it is a conductive type or sensory type. So first of all, we will do the voice test. Okay. So we start with at a distance of 2 feet, about this length, and we explain to the patient that what I'm going to repeat few bisyllables first, and the patient has to repeat after me. And I have to mask the other ear with my finger and hide the patient's eyes so that the patient does not lip read. If the patient can hear at a distance of 2 feet, and we use the normal conversation voice, we do not shout, we do not whisper, normal conversation voice. And if the patient can repeat at a distance of 2 feet, that means patient has got normal hearing, or maybe some hearing loss of between 0 to 30 decibel. Between 0 to 20 decibel, we take it normal hearing. So patient may have a mild hearing loss. If the patient cannot hear at a distance of 2 feet, then we move forward at a distance of 1 feet. If the patient can hear my voice, then it means the patient hearing loss is between 30 and 60 decibel. If patient cannot hear at a distance of 1 feet, then I will go very close to the pinna and ear canal and repeat the bisyllable words in conversation voice. If the patient can hear, that means the patient hearing loss is more than 60 decibel. If the patient cannot hear even then I will raise my voice volume. If the patient cannot hear that, it means the patient has got a dead ear. So this is basically a rough way of assessing the hearing threshold. Okay, so I will demonstrate now. कुछ लफ्ज़ बोलूँगा, आपको repeat करना है, बहुत से सुनिएगा. You hide the patient's eye like this so that they do not lip read. You mask the other ear so that patient does not hear from that ear. Here, you press the triggers like that. Keep pressing in and out. This is a way of masking the air conduction from the other ear. And it is about 2 feet. I will say a few bisyllables for that. So you have noticed that I have used with voice in a normal conversation, loud intensity, and patient could repeat. So either patient has got a normal hearing or less than 30 decibel hearing loss. If the patient cannot hear, then I will go closer, repeat that. If the patient cannot hear, then I will go very close to the pinna. So you repeat the same on the other side. Then comes the various type of tuning fork test. These tuning fork tests, we basically want to see whether patient has got a deafness, if patient has got a deafness, whether it is conductive or sensory. They comes in various frequencies. Now I am going to talk briefly about tuning fork test. This is a box which contains various types of tuning fork test and with various frequencies. Frequencies are mentioned here. This is 512. This is 256. So they come in various frequencies. This is 1024. Normally we use 512 frequency for tuning fork test. If you use higher frequency like 1024, then it will fade very easily, because when you strike with your knee or elbow, then it causes some vibration. The higher the frequency, the earlier it will be fading away, so patient may not be able to hear properly. If you use lower frequency, then it will give the sensation of it will not give the hearing sensation, but it will give this sensory sensation, like sensation of feeling something. So it will not be auditory test. So that is why we use 512 tuning fork in most of the cases. There are certain instances in which you can use a higher frequency and lower frequency, but I think that is not for the undergraduate level. So I will focus on this 512 frequency. So whenever you are asked to do a tuning fork test, and if you have got lots of tuning fork tests in front of you, you must pick up and look and see the 512 frequency. There are various types of tuning fork tests: Weber's test, Wheely's test, Schauberg's test. Normally Weber's and Wheely's tests are adequate, and there are various ways of performing these tests. I will explain to you in a very simple term how to do a Weber's test and Wheely's test. First, little bit background. If patient gets hearing is normal in both sides, what we are going to talk about Weber's test. What we do is use a 512 Hz tuning fork, and you have to strike with your knee or with your elbow in a way that it is not loud, that it should not be heard by any other person. It should be heard only by the patient. It should not be very loud. A lot of students forget about this. They sometimes start hitting there or hitting like this. The best way is, without causing any trauma to yourself or your elbow, knee is the best place. Very lightly you tap it there, and then you hear in your ear that you can hear it, and then you use it on the patient. So this is where how you tap it. You can do it here, but I prefer here because you are wearing trouser or some clothing, so it protects against causing unnecessary discomfort to yourself. So don't cause any discomfort to yourself as well apart from the patient. So in the Weber's test, you put the tuning fork. This is the side which you vibrate, and this is the side which you put on the patient's forehead, like that. And ask the patient whether the patient can hear in the center, right or left. If the patient has got a normal hearing, patient will hear in the center. If the patient has got conductive deafness, for example in the right ear, Weber will lateralize to the right ear. We will put there, and if the patient can hear in the midline, in the center, that means he has got normal hearing. If it is lateralized to the deaf ear, that means got a conductive deafness. If patient can hear on the normal ear, then that means the patient has got a sensorineural deafness on the affected ear. So I will repeat. If the patient can hear, for example, patient complain of deafness in the right ear, and if the patient can hear the tuning fork better on the right side, on the deaf ear, that means patient has got conductive deafness. If the patient can hear better on the normal side, that is on the contralateral side, which we presume is normal, then it means patient has got a sensorineural deafness. Now I will demonstrate. Okay? You have to explain to the patient. मैं आपको यहाँ रखूँगा, आप बताइएगा आपको बीच में आवाज़ आती है, इधर आती है, इधर आती है, ठीक है? आप उसको try like that. बीच में. This patient can hear in the center. That means both ears are normal. If it is lateralized to one side, for example, if this was deaf ear and he said he can hear better on this side, then that means patient has got a conductive deafness. If he could hear better on the good ear, then it means that on this side patient has got a sensorineural deafness. So this is Weber's test. Now, I'm not going to in detail about how much hearing loss patient may have, but just briefly, if Weber is lateralized to the conductive deafness ear, to the deaf ear, then this patient has got a conductive deafness, and at least minimum patient has got a hearing loss of 15 to 25 decibels. Then I will do the Venus test. I will perform in the same fashion, but I will first put in the front of the pinna and then behind. And I will explain to the patient that this is number 1, that is number 2, and which ear is he can hear better. If the patient can hear better in the front of the pinna, then either patient has got a normal hearing, or even patient with a mild to moderate sensorineural deafness, patient would hear better on the front. That means air conduction is better than bone conduction. So either patient has got a normal hearing or a sensorineural deafness, and we call it Venus positive. However, if the patient can hear better on the back of the pinna where we put it on the mastoid like that, that means bone conduction is better than air conduction. So if bone conduction is better than air conduction, we call it Weber's negative, and that means patient has got a conductive deafness. However, one point to remember, whenever we are doing bone conduction, patient may hear on the other side. So if patient say, I can hear better on the back of the pinna, so either patient, this is a Venus negative, but it could be false negative because patient may be hearing from the other side. So the other ear you have to mask with a device called Barani noise box. You don't have Barani noise box, but you put it there and it produces some sounds, and ask the patient to concentrate there. If patient can still hear better on this side, then it means patient has got a true negative Venus test. The patient has got a conductive deafness. Okay. There are various ways of doing Venus test. In some books you will read that you will ask the patient when you stop hearing, you will put it there. You will ask the patient when you can stop hearing. then patient says yes, I cannot hear, and then you put it there, patient says I can hear, that means air conduction is better. But that is sometimes confusing, so simplest is I will demonstrate. Again strike it, आगे रखूँगा पीछे रखूँगा, अब बताइएगा आगे वाली तेज है या पीछे वाली तेज? आगे पीछे आगे वाली तेज. That means the patient has got venous positive. Okay. So if the voice test shows the patient has got some hearing loss, as I demonstrated earlier, the patient cannot hear 2 feet, but patient can hear 30 feet at 1 feet. That means patient has got hearing loss of about 30 to 60 decibel. And venous is positive, then it means that patient will have sensory neural deafness, and the fiber will lateralize to the normal ear. This is the end of the tuning fork test. There are other tuning fork tests, but I think these 2 tests give us adequate information. Okay. Now, if you are doing an ear examination, you have to also test the balance part of the ear. Obviously, you don't do the balance test in every patient with the ear problem. Only you do it in patients who complain of vertigo. So I will briefly demonstrate 2 or 3 balance tests to check the function of the labyrinth and cerebellum. What we first want to do is examine the eye and look for the nystagmus. If there is a nystagmus visible, then patient has got some acute problem with labyrinth. There are various types of nystagmus, peripheral and central. The patient may have got problem with labyrinth or cerebellar problem, but I am not going to go in detail about various types of nystagmus, which will be taught to you people in one of the lectures and tutorials. But this is basically to demonstrate the balance test. So you rotate the patient and sit like this and examine the eyes and ask the patient to follow your finger. Basically you are looking for the nystagmus, and if there is a nystagmus, then it will be visible like that. Then you want to see whether the patient has got a tremor, because there are some cerebellar disease which can cause vertigo and tremor. You ask the patient to raise the hand like this and spread finger and see if there are any tremor. In some cases, if you want to be absolutely certain, what you do, you take a piece of paper and put it there and see if there is a tremor or not. Okay. Once you have done that, that is a test called finger nose test. Basically, you want to see coordination. In cerebellar disorder, patient may have poor coordination. So you ask a patient that you touch your finger, my finger, and then your nose like this, with eyes open and with eyes closed, so that you want to see the patient coordination. Yeah, उंगली आगे रखूँगा, आपको उंगली यहाँ लगानी है, फिर अपनी नाक में लगानी है, और जल्दी जल्दी करना है. पहले आँखें खोल के करना, फिर आँखें बंद करके चलें. जल्दी, quick. अब आँखें बंद करके करें. Okay. Now, you must have noticed that I changed the position of my finger with his eyes open. So I want to see whether his coordination is right. Maybe he is trained on this side, but if I change my position, whether his cerebellum has learned to locate where my finger is. So you put it in, you keep your fingers in various positions. But when you are doing it with eyes closed, obviously you have to keep it in one place. So this is called finger nose test. Then you do a test called balance test. You ask the patient to stand up, take off their shoes, and if, as you know, the balance is controlled by your labyrinth, by input from your eyes, and by proprioceptor from your joints. So normally all these 3 inputs reaches to your labyrinth, and that control your balance. Now if one of these is not functioning, patient balance may not be too bad if they are standing, but if out of these 3, 2 are not functioning, and you ask the patient to stand, they will fall. So because we are an ENT doctor, most of the patients who come to us, they have got other labyrinth problem, or maybe a central problem. If they have got some problem with their vision, they will go to the eye doctor. So what we do, assuming that patient may have a labyrinth disorder, we ask the patient to stand. Now, if labyrinth is not working, he is getting the impulse input from his proprioceptors and from the eyes. So we ask the patient to close the eyes so that we remove that input or signal from his eyes. Now the two of the things are, if these two are not working, then the patient is going to sway to one side or may even fall. I will demonstrate. Yeah, you should choose something. Now patient is stand like this. Suppose his labyrinth is not working, but he is getting input from his proprioceptors and from his eye, so patient will not sway, will not fall. Now ask the patient to close the eyes. आंखें बंद करें. So if there is an acute labyrinthine disorder or cerebral disorder, the patient may sway to one side or may even fall. This is called Romberg test. If it is normal, you call it Romberg. If it is positive, it is abnormal, then you have to call it Romberg negative. Then you check the gait of the patient. Ask the patient to walk along a straight line with the eyes open. See the bullet? And you watch the gait, whether it is straight or it is swaying to one side or other side. Now then you ask the patient to do it with the eyes closed. आंखें बंद करें. बगैर सहारा लिए, सहारा छोड़ दे, सीधे चले बस, जरूरी नहीं करना है. So this is how you check the gait. So this is a quick, brief labyrinthine examination. There are other sophisticated tests available to check the labyrinth, which we are not going to demonstrate here, like caloric test or an electrodystagmography. But remember one thing: in a patient of vertigo, history is the most important part of clinical examination. If by the end of the history you have not have any idea about the diagnosis, then despite the various tests, even sophisticated tests like electrodystagmography, you may tell that patient labyrinth is not working, but you will not know the diagnosis, why it is not working, what is the underlying pathology. History is imperative in every case, but especially in vertigo you have to take a detailed history. So this is, I think, complete examination of the ear. So I will summarize, apart from position of the patient, taking the consent of the patient, explaining to the patient, you start with inspection of the ear, and then palpation of the ear, and then use the single speculum and examine the ear canal and the tympanic membrane, then use the otoscope, and then you may have to use the pneumatic speculum with the otoscope. Then you do the auditory assessment, clinical auditory assessment by voice test and tuning fork test. Basically Weber's and Williams, and then you do the balance test. Now one thing is very important, facial nerve. Obviously you do not examine the facial nerve in every patient, but there are a lot of disease in ear or parotid region. Patient may come present to ENT with a facial paralysis. If there is ear is abnormal, there are some condition in which there is an infection like chronic suppurative otitis media, which is called struma. It may erode the facial nerve canal which goes through the middle ear, and patient may present with facial palsy. If there is a disease in the parotid region like malignancy of parotid, patient may present with facial palsy. However, most common cause of facial palsy is idiopathic, which we call it Bell's palsy. So you must know how to examine the facial nerve. Obviously you may have to examine other cranial nerves. But the facial nerve is, first of all, when you are talking to the patient, in a very early case, patient may not notice it. In a very early case, if patient is developing facial paralysis for whatever the reason, there may be reduced blinking of the eyes. I have had many patients who were not aware of that they are developing facial weakness, and on this stage, if you are talking to them, you notice that their blinking is reduced. However, the majority of the patient come to us, they already have got facial palsy. So as you know, there are 5 branches of the facial nerve: temporal, zygomatic, buccal, marginal mandibular, and cervical. So you examine all these nerves. So first of all, you ask the patient to look up and look at the frowning. If there is normal frowning, then that means facial nerve is normal. If facial nerve is paralyzed on that side, they may not be frowning. Ask the patient to close the eyes. आंखें बंद करें, मुझे आँखें खोलने नहीं दीजिएगा. Ask the patient to close the eyes tightly and don't let him. Ask them that don't let me open the eyes, and then you open the eyes. So you see, you can't open the eyes. You can't open the eyes. But if there is a facial paralysis of grade 3 or 4, or you do like that, then you will be able to open the eyes. Okay, Paulina? Then you want to see the angle of the mouth. So ask the patient, दांत दिखाएं. So if it is symmetrical, if there is facial palsy, there will be asymmetry of the angle. फिर आप पेशेंट को कहते हैं, you ask them to puff some air in their mouth. You got it? And you check the tone of these buccinator muscle. If there is a facial palsy, as soon as you do that, there will be air leak there. So this is how you examine the facial nerve.